All right, good morning, everyone. Just checking in if everybody can hear me now clearly and see me. Okay, perfect. So welcome to our first of the Community of Practice Implementation Series webinars. This is a three-part webinar series, and it's primarily going to be focusing on implementing tobacco cessation programming. And we're hoping that this is going to explore frameworks and make recommendations and strategies to successfully implement tobacco cessation within different settings. The first of the series today is going to be presented by Dr. Nadia Minian and Sarwar Hussan, and they're going to be presenting specifically on enhancing tobacco control in Ontario by adapting the interactive system framework. Just a few housekeeping slides, as we always do. I'll let you take a moment to read through those. Again, our webinars are being live tweeted on Twitter, so if you do tweet, we ask that you'll follow along at PS Quit Smoking and share some of the insights and perhaps comments that you have as well on Twitter. A bit about our presenter. So Dr. Nadia Minian is a knowledge translation and evaluation scientist at the Nicotine Dependence Service here at CAMH. And she works to ensure and continually strive towards delivering the highest quality and most efficient services possible so that the best outcomes can be achieved for Ontario smokers. And Sarwar is actually one of the managers of the Nicotine Dependence Service at CAMH as well, and he's been with the NDS for a long time in his capacities as program coordinator and project manager of the STOP program. He has helped to also write reports and analyze and published and presented a variety of different papers and peer-reviewed journals as well. So as a note, both our presenters do not have any items to disclose. The Teach curriculum slides and slides are developed and compiled with funding from the Government of Ontario, specifically Ministry of Health and Long-Term Care. And the contents of our slides are primarily evidence-based, and they come from the following 3 guidelines. Again, these materials, as well as the verbal presentations and any discussions, whether that come from our presenters or in the chat box, are really only set out as general principles and approaches to assessment and treatment pertaining to tobacco cessation interventions. They do not constitute clinical or other advice as to a particular situation and do not replace the need for individualized clinical assessment and treatment plans. Okay, so to start us off, I'm going to hand it over to our presenters. So they'll be taking over and they'll lead us through the presentation. So I'd like to welcome them.
Thank you, Leah, for the presentation, and thanks for inviting us. Both Sarwar and I are very excited to be here sharing with all of you, what we have learned about how to really move research into practice in a more timely manner. So the 2 learning objectives we have for today is to share with you how we have adapted a framework that was developed by the Center for Disease Control in the States called the Interactive System Framework into our practice here at CAMH. Our second objective is to show how this framework really helps explain the approach we've been using to help smoking cessation throughout the province. And why is this important? A lot of times I keep on hearing that tobacco control is a done deal. We've achieved quite a bit. The smoking prevalence has been going down in the last 10, 15 years in Canada and in Ontario. So why do we need a framework for this? And I find it quite surprising because we still have 37,000 Canadians dying each year because of their addiction towards tobacco. That's the same as if a plane was crashing each week and everyone was dying within the week that was in the plane. And we thought that was enough. I'm sure that if that was the case, we would want to see how we were building our planes, looking into the engines, looking into the flight conditions, looking into the trainings we provide to the pilots in order to avoid a plane crashing each week and having such a tremendous loss. So we're doing the same within tobacco control, although the evidence we get is a bit different. And we've used the National Center for Collaborating Methods and Tools to see what evidence should we include when looking at what we should do for tobacco control or for public health in general. And they have a very comprehensive list, mainly summarized in 4 different points. One is looking into the local context is really important, looking into the public health resources and what's available there. Looking into the community and political climate will inform what we can and what we cannot do. And lastly is looking at the best available research findings. And what they mean by best available research findings is summarized within this pyramid. So at the bottom, we have single studies, and this is the less ideal to use, followed by synopsis of single studies, then by synthesis of several studies together, and then the more promising things and the preferred way of using is using summaries and systems. And this includes pre-appraising the studies, so making sure they're good quality, summarizing them, and having actionable messages. We have to be careful, though, that we don't wait until we have too much data and too much information if the problem is big enough and we have enough evidence. We don't want to be like the 2 people in this island that are waiting to have absolute certainty in order to act and avoid the tsunami. Also, we have to be careful on what is the right evidence. A lot of the times I keep on hearing randomized controlled trials, for example, are stated as the gold standard. And yes, they are the gold standard for certain contexts. However, I imagine that no one would recommend doing a randomized controlled trial to see if parachutes work or not. So just to, when we're appraising the evidence, be critical about what the context is, what the questions we're asking, and what really can be the right methods and tools to use. So again, this summarizes where we can get all the evidence from. And in tobacco control, we're really, really fortunate because we have lots of evidence. We have lots of journal articles coming almost every week showing what are promising strategies in order to help smokers quit. We have systematic reviews with actionable messages, both internationally and national ones, and each time more and more journal articles that can be incorporated into the systematic reviews. So we have lots to work on. Unfortunately, we're not always updating our programs and working with the best available evidence. And one of the studies I've seen shows that there's about an 18 to 30-year gap between us having evidence and then putting it into practice. And when 37,000 Canadians are dying because of this, I think we need to act in a bit more speedy manner. And then the NicotineDependence Services, which is where I work, which is located at the Center for Addiction and Mental Health, we have developed several projects that teach, the stop, can adapt, and pregnant among them in order to help move smoking cessation in our province forward. We've been using the interactive systems framework, as I've mentioned at the beginning of the slides, to really structure our work. And this framework suggests that there needs to be 3 different systems in place that interact with one another in order to move or to spread what we know, spread programs throughout. So this framework is not to start with building evidence, but it's based on once we know what the evidence is, once we've tested some programs, how do we spread it so that there's more adoption throughout the province or the country. So one of the things I've heard lately is that at times it seems that we need a little bit less innovation and a lot more imitation. So in a way, this framework is to help with the imitation. And the first system in the ISF framework is the synthesis and translation system. And this is really saying that research findings need to be put into accessible and friendly formats that are actionable. So what have we done at the NDS, at the Nicotine Dependence Services, to help build this system? We've built a website. It's called Pregnant, and its purpose is to help pregnant women as well as healthcare providers help pregnant women quit smoking. It provides evidence-based information, and it allows pregnant women to post anonymous questions in the website and get answers from healthcare providers. This was set because a lot of researchers were finding, and a lot of practitioners were finding, that pregnant women were too embarrassed to disclose that they were smoking while they were pregnant to their healthcare provider. So it's really providing them with a new avenue of how to access this information. Another way that we've put research findings into actionable formats is the Duct Guidelines. Again, there's a lot of research out there, and sometimes it's hard to swift through everything. So the Duct Guidelines got, I think, over 1,000 stakeholders throughout our country together to develop different guidelines on how to help healthcare providers provide information to help smokers quit. We've also have a YouTube channel in where we have over 70 videos to help healthcare providers have information on how to talk to smokers about quitting. So it's a lot of videos about motivational interviewing, as well as direct information on how to help people quit smoking. We've also developed a lot of course manuals that have actionable information in them. The second system in the ISF framework is the support system. And this really is a system where we're building the capacity. The ISM framework is very clear that we cannot move any research forward if we do not have, if we're not building the capacity within our system. And this capacity is not only specific to what the topic you're dealing is, but there's also a general capacity building. So for us, we have TEACH, which I'm sure you're all very familiar with, but just for those of you who might not be, TEACH is a program that trains healthcare providers in smoking cessation. And it's a 40-hour course, so it's quite intensive, and then there's specialty courses that are offered throughout the year. Now you can do it both online or as an in-person. TEACH not only provides healthcare providers with information about smoking cessation, but also on motivational interviewing, which is the general capacity building that the ISF framework talks about. The third system is the delivery system. And this is really where you put your innovation into practice. So for us, we have two different ways of doing this. The first one is a clinic that we have here at CAMH, where we see about 1,000 smokers each year, which are quite complex cases, and we help them throughout their quit journey. The second program that we have in the delivery system is the STOP program. And this is a program we have throughout Ontario, where we've partnered with public health units, with primary care, such as CHCs and family health teams. We've now practiced also with nurse practitioner-led clinics and with addiction agencies in order to provide evidence-based treatment to the smokers. So as you can see, here's the ISF framework, and we've mapped into the three systems in order to help Ontarians quit smoking. However, what I find is really important is the interaction between the systems. There has to be constant communication between one system and the other so that information doesn't become stagnant. So there has to be really an emphasis on cross-program integration. And this has been a focal point for us at the NDS. So what have we done? And a lot of what we do is through the communities of practice, like the one you belong, where you receive information through listservs. You're coached by NDS staff. We develop trainer toolkits. We have teleconference, lunch and learn webinars, and regional practice leaders. And all of this helps inform what our next steps should be, as well as help disseminate some of the things we are developing. Another important thing for us is the evaluations we constantly are doing, both ourselves or through the Ontario Tobacco Research Unit. And the information we get from these evaluations really help us decide what our next steps should be. So, for example, let me go through these quickly. These are the 3 systems that we have that I've talked at length, I think, about. And here is how we really communicate between the 3 systems. So we decide what tools need to be developed depending on what participants from the TEACH training tell us. We use the training, we've used some of the YouTube information, the YouTube videos that we have, as well as the Canada guidelines and pregnant, in order to inform our training. The tools are developed using information that comes from implementation. So STOP implementers will come with questions about some of the things they're seeing in the field, and we'll adapt some of the tools we develop. So for example, within the STOP, e-cigarettes was coming quite a bit. They needed some answers. So now Lori, which is one of our scientists here at the NDS, is doing a study to try to understand really more about e-cigarettes and what are the implications for us in Ontario. How implementations inform research projects is questions arising during the implementation guide the tools. So from the e-cigarette study, for example, I'm sure we will be developing some tools that will help within the delivery system. Training informs implementation, as training provides the evidence base for healthcare providers to act. And questions arising during implementation guide also our future training. So for example, when we hear that there's a need for an Aboriginal course or for courses about youth or about women, we go ahead and develop new TEACH trainings. These are also based depending on what the literature says and whether we have information to update what we have or not. So by using this system, we've really helped Ontarian smokers quit. Within the TEACH program, we've trained over 5,000 healthcare providers. Pregnant reaches over 1,000 people each month. And the STOP program, since its inception, has helped over 125,000 people quit. We're not saying the 125,000 have quit, but all of them have received evidence-based information and an evidence-based treatment in order to help them with their quit process. So I hope this has helped you understand how the ISF model works and how it really can help you have that safe flight instead of having a plane crashing every week. And with that, I will pass it on to Sarwar, who will talk to you more about how STOP and the STOP program fit into the ISF model.
Thank you, Nadia. Very informative session, obviously, on a very important way of approaching integration of research into practice, or more importantly, translation of research into practice without the lengthy traditional delay that we often see, which sometimes is 18, 19 years. So what I'm going to do over the next little while is take that conceptual framework and demonstrate how we have been able to implement that through the integration of the STOP program at various healthcare organizations across the province of Ontario. And so most of you, I assume, would be familiar with the STOP program, but in case you are not, what it is really is a first of its kind project within this country that has so far, since 2005, late 2005 is when we actually initiated the STOP program at three different tertiary care centers across Ontario. And since then, we have obviously grown to involve a great number of different types of healthcare organizations, as you can see on this slide. But really, it is an unprecedented smoking cessation program within the Canadian context. And as far as we know, really within the international context as well. There are components of the STOP program that have been replicated or were done previous to the STOP program in other jurisdictions, but as a whole, this is really quite an innovative strategy that we have been able to implement within the province of Ontario. And so far, we have been able to deliver treatment, smoking cessation treatment that involves both pharmacotherapy and behavioral intervention to well over 100,000 individuals across the province of Ontario. At last count, really, it was about 125,000 just a couple of weeks ago. And you'll see the variety of different healthcare organizations that we have been able to integrate with, both within the primary care sector, but also within the community as well, with the public health units and health promotions, et cetera. So together, overall, there are about more than 200 different organizations and well over 500 practitioners, and it's a growing list of practitioners who are integrating the STOP program and using what we call the STOP portal, and that's our electronic data capture system that we have rolled into the project partway after initiation of the project, and that allows for practitioners to input data electronically as opposed to collecting them on paper-based forms, which we had initially started with, and then transitioned over to this electronic system. And we'll come back to that a little bit later. But just before that, a quick commentary around our approach. Our approach is a pragmatic approach, something that will really work within the real world setting. A pragmatic approach to what? To innovating models of care delivery. And this is really the key here. We have to innovate models because there have to be different strategies for different settings. And that's the first key principle that we had developed for ourselves in terms of what we need to stick with in implementing this project successfully. And so models of care delivery that have to be designed, which are ways of working with the existing processes within these healthcare provider organizations. And that's really important because what we want to do is we want to minimize disruptions. Our purpose here is not to build efficiency within the healthcare organizations that we work with, but find efficient ways of integrating smoking cessation intervention as part of their regular practice. And this is what it is that we believe will lead to higher rates of adoptions, and therefore that will then translate into higher reach within the patient population. So that's the statement of our approach. About the principle or the philosophy behind our approach. However, it's a philosophy that does remain entirely in alignment with the three components of the ISF framework that Nadia just presented to you. And just to remind ourselves, the three components are, again, prevention, synthesis of information and translation, and then prevention support system, and then also prevention delivery system. And so we see these three components play out in the major activities that were part of the STOP implementation strategy. And in this diagram, what I have done is presented for you the major activities that were involved in the STOP program that began with the introduction of the program to the different organizations and sites, and then finally development of the program and then implementation of the delivery of intervention. And with that diagram, what I want to do is map those three components of the ISF onto the activities of this project and demonstrate to you how we have been able to align the ISF framework within our approach here. And so you will see that the capacity assessment Really, actually, I'll go back here. We consider the capacity assessment that immediately followed the introduction or the invitation to participate in the STAR program. Is really a phase where we synthesize the information not only from the published literature, but also from the organizations themselves, so that we can come up with actionable items in terms of what evidence can be implemented in what way within the organizations that we are implementing the STOP program. And so that led to accumulation of this evidence-based actionable items into protocols and algorithms. The next part of it was to then focus on the support system. What do we need in order for those actionable items to be implemented within this organization? So we needed to provide or avail trainings related to application of this protocol, but also training related to the subject matter expertise. And then the other component of our activity, which is probably the most prominent aspect of the STOP program, and as Nadia has correctly grouped the STOP program within the delivery system in the ISF framework, there are major activities related to that focus on building the system, maintaining the system, and then continuously improving the system. And we will touch on this as we go on over the next few slides. So let's first focus on the synthesis component. So what we did with the STOP program, first of all, was to send out an invitation, and along with the invitation to participate in the program, agencies also received a capacity assessment survey, essentially a tool that would allow us to collect information about the characteristics of the organization, how they operate, etc. And I'm going to use our implementation with the addictions agencies as an example of how we have done that. So in 2012 and 2013, we sent out invitations to all addiction agencies within Ontario using the Connects Ontario database. And there were about 190 or 198 to be exact agencies on the database. Purpose was to gauge interest, but also collect capacity related information. And 68 agencies at that time, after the first round of invitation, had responded to the survey. This was important because we wanted to know from the agencies how they operate and did not want to make assumptions and therefore lead to erroneous models of care delivery that would ultimately prove to be not so feasible within this organization. So what did we learn from these capacity assessment surveys? What we learned is that 75% of addiction agencies' clients smoke cigarettes. That's not a surprise. I mean, that's well over the general population levels, but we knew always that within the addictions population, there is going to be higher rates of smoking cessation. So that confirms our understanding to some extent. Maybe 75 would prove to be a little bit higher than what we would have assumed, or a little bit lower, but nonetheless, this is what it is within this sector in Ontario. And then we wanted to know, we learned about the types of agencies they are. Some of them are outpatient agencies that are community treatment services. Others are inpatient, more intensive residential treatment services. And we've got a breakdown of how many of them offer which types of services. And then also with respect to what are they already doing that are related to smoking cessation directly or could be leveraged in terms of building a smoking cessation strategy within those organizations. So you can see, I'm not going to go through all of them, but you can see some of the metrics that we collected related to that in terms of services that they offer, services that they link their clients to within the community and within the healthcare sector in general. And then we complemented that information that we collected through the survey through a conversation with each of those agencies. And this was important because quantitative information give you a certain level of understanding about how an organization operates. But we needed to understand at a more qualitative level in terms of how these agencies are operating, what works, what doesn't work, etc. And so we set up immediately following the initial capacity assessment survey, initial discussions, what we call them, initial discussions to discuss with each agency one-on-one some of the results that we observed in the survey, but also other items that are related to their operations and how they view smoking cessation or the placement of smoking cessation intervention within their overall agenda. So that was really a strategy to collect information, collect evidence. So this is another type of evidence that we needed to collect in order to come up with the actionable items that will work within those settings. And so that in combination with what the literature would tell us about what is effective and what is not effective, we came up with these 4 clusters of sort of actions that can be taken, or 4 clusters of interventions. And you'll see here that they will range in the intensity, in terms of intensity of behavioral intervention, but also length of pharmacotherapy from one to other. And they will also differ based on whether or not the mode of care delivery is individualized versus group therapy. And really, this then becomes the sort of list or the menu of options that the agencies could pick from depending on their setting and what would be most feasible within their setting. And so all of that was then accumulated into our operations manual, and that became therefore the synthesis and the translation of the knowledge into actionable items that can be implemented within these organizations. With that said, let's focus on some of the other key elements of this engagement strategy, facilitators of engagement. I mean, with the addictions agencies, we got about 30% responding initially, but when we engaged with the family health teams, we got well over 50% initially responding, and right now we're sitting at a point where 75% of the addictions agencies are of the family health teams are implementing the STOP program. About 70 or 78 or 80% of the community health centers are implementing the STOP program. Almost all of the public health units, 34 out of the 36, are implementing the STOP program. So the adoption rate is much higher within those other organizations than the addictions agency, but still we are seeing a good level of adoption within the addiction agencies as well. But what can be attributed to that high levels of adoption within the addiction sector, but also within the other sectors? One of the key things that we discovered was that when we leveraged the Ministry of Health Promotion, who was ultimately funding these organizations, in sending out the invitation, generating interest, we found a pretty incredibly high rate of response in terms of interest. And that makes sense because the ministry is funding these organizations, and so therefore the ministry does have quite a bit of sway over them. And so that was an important point of advantage in terms of engaging these organizations. Also, what was useful was that we stated out front at the beginning that our intention is to develop something collaboratively within this organization and not necessarily develop something and then impose it on them. And all of that then led to a buy-in from their executive level leadership, which then translated into a memorandum of understanding or collaborative agreements with these organizations. And when we had that buy-in at that executive level, this then shifted the conversation at the front line from why should we do this to how should we do this. And that was a critical transformation in terms of the conversation that we needed to have, because we did not want to focus on why we should do this. I think Nadia made the case generally earlier why we should focus on smoking cessation. But here we're talking about implementation and dissemination. We're really focused on how should we do this. And there are different ways of doing it, and part of the process of collecting information and evidence from the sites with respect to how they operate was part of that conversation in determining how we can do this. So then, excuse me. So then let's move on to some of the facilitators of implementation. And really, this is where we then touch on to the next component of the ISF framework, and that is the support system for practitioners. Because it's not good enough to just simply develop a model, develop a strategy, and then leave it up to the organizations or practitioners to say, okay, this is what it is, and you implement it. We have seen it play out over and over again throughout the history of healthcare intervention models. Just simply developing an intervention model doesn't work. You have to have the support system in place to enable the practitioners and organizations to actually implement it. And out here, one of the critical things that we did was not only focus on the subject matter expertise or training related to subject matter, which is here obviously smoking cessation intervention, but also training related to the application of the protocol, application of the actionable items that we had developed earlier. So those are the two critical components of our support system here. And this is where we leverage our sister project, the Teach project here, to develop the content, develop and deliver the content in terms of the training. And the other aspect that we learned from the capacity assessment survey was that organizations have varying levels of appetite for different types of training, or different modalities of training, meaning some could attend and provide their staff for intensive trainings, others could not do that. Some could attend in person, but others could only attend via virtual media. And so therefore, we had to come up with a flexible training schedule that would allow for different modalities to be implemented. And that was important too, because again, similar to developing a model and then hoping that it work. We don't want to end up in a place where we develop training and hope that people would come. We have to develop training that are acceptable or workable within the busy practice settings, within the busy practitioner's schedule, and so therefore ultimately having a higher adoption rate for training as well. So then with the prevention system, with the synthesis of information, we can now focus on the delivery of the implementation. And the delivery system, that is the STOP program, has several key features built into it on purpose. One of them, as I mentioned, it is a pragmatic system built around real-world constraint, and that really has to be a primary focus, because again, feasibility is a key intention here. And then it has to be dynamic and responsive. And Nadia talked about this a little bit as well. It has to be dynamic and responsive to changes that are required to be made as the program is being implemented. So there has to be mechanisms of change put in place. And one of the examples that I mentioned earlier was initially when we deployed the STOP program across these organizations, our method of data collection was paper-based. And there's some conveniences related to that. However, what we heard back from the practitioners is that the administrative burden that carried was becoming prohibitive in many sense, prohibitive in terms of enrolling more patients, prohibitive in the sense that even implementing the project in its entirety was becoming questionable. So then we looked into a electronic method for collecting and curating the information. And so therefore, over the following year and a half, we invested quite a lot of resources as well as feedback from the practitioners into developing the electronic portal system that we call the STOP portal. And right now we're at a point where about 85% of the new enrollments are completed on the portal, and nearly 100% of the visit forms or the data collected at subsequent visits are directly entered into the portal. And it is a web-based portal, so it is pretty much accessible from anywhere. It is not integrated with the EMRs at these organizations. I mean, that was a project element that was well beyond the scope of the STOP program. Ideally, of course, those would be integrated, but for the time being, they are not. They are a parallel system. However, we can push information from our STOP portal into the EMRs through PDFs and other documents. And then the third key feature of the delivery system of the STOP program is that we did not intentionally set out to create additional demand or demand for additional positions within these organizations to implement the STOP program. What we did really push for or encourage is that let's look at the scope of practice and see if there is room there to expand the scope of practice of the current staffing level to integrate the STOP program within their routine care. And I don't have any statistics to present around that, but I believe based on our conversations with these organizations, it is their existing staff who were then ultimately responsible for delivering the care through integration of the STOP program. And as based on our recruitment rates, I think that we can say that for these organizations that are participating within the STOP program, this is a model that is working out well. There may be room for improvement, but it is nonetheless working out well. The other key element is to integrate smoking cessation intervention as part of the performance targets for both the staff and the organizations. And this is really critically important because, again, we measure how we are doing in terms of what we set out to do by measuring what we have been able to achieve at the end of the year. And so therefore, we help with measuring some of those aspects by providing feedback reports to these organizations so that they can see how well they're performing, because they've invested resources and they want to be able to say and demonstrate that the return on investment has been as they expected, or whatever the target was. Essentially, there has to be some measure of understanding so that they know what they're getting from it, but also it's a measure of how we are doing, essentially getting people accountable for the commitment that we have made. Along with that, as part of the dynamic responsive system as well, we need to have a knowledge exchange forum that is in place that can allow us to collect feedback from these organizations, from the practitioners, and then be able to respond to those feedback so that it becomes a system that is a live system, that not a static one, something that is vibrant, something that is relevant, and those are really the key aspects of a delivery system that really works well for the time and that will continue to work as the project progresses into the future. And so here on the slide, you can see some of the mechanisms that we have for collecting knowledge and exchanging knowledge among the practitioners. We have a bi-weekly teleconference, and then we learn what is working, what is not working, and then come up with strategies to address those. And then also other mechanisms through webinars such as Lunch and Learn webinars, where we can then deploy information to not only that population, but also the greater community of practice. So my key takeaway messages from all of this is, first of all, one, is that whereas previously smoking cessation was not necessarily thought to be part of the routine care in primary care or specialized care like in addiction services or addictions agencies, it is now no longer an unfamiliar idea within those contexts because they are doing it and they're happy to do it is what we hear. It's just a way of finding feasible ways of doing it. So that's the first message, is that we are moving that sort of attitude towards smoking cessation away from the traditional one where it was, it's not my job, it should be someone else's, but towards one where let's see what we can do about it and then provide the services that our patients ultimately need in order to improve their overall quality of health. And the second message is a bit of a philosophical one, but for this one I will draw an analogy here. The analogy is a flock of birds. And when you look at a flying flock of birds, you will see that it operates like a very complex organism. I mean, it moves, but at the same time, it seems to be coherent, even though there are literally thousands, hundreds of thousands, millions of birds in the flock of birds. So it is a very complex system. Similarly, smoking cessation integration within this complex organization, such as family health teams, community health centers, addictions agencies, may seem like a complex system as well. And in fact, it is. But it may, more importantly, seem to be very daunting and initially prove to be very demanding that cannot be implemented within those organizations. However, studies of complex system sciences tell us that complex systems don't necessarily require the level of kind of investment that we initially assume that they need. And there are, in fact, simple rules that can be implemented in order to guide a complex system. So for a flock of birds, there are 3 simple rules, really. One is that stay close to, if you're a bird, stay in that flock of birds, stay close to your neighbor, but do not bump into them. Second is fly at the same speed as your neighbor. And then third, move towards the center of the group. And all of those 3 rules, when they're implemented, results in what we see a flock of birds do. And this has been simulated in computerized models as well. So what are the 3 simple rules within our complex system of integrating the STOP program within these various different healthcare organizations? I would say the first one is getting executive level adoption, that sponsorship, that ultimately leads to moving the conversation from why should we do this to how should we do this. The second is a structured training to introduce or enhance competency at point of care. And this is the support system of the integrated framework. And the third is a statement of accountability at the individual staff level as well as the organization level. And we have established that through executed memorandums of understandings. And that's really important because that keeps us honest, keeps us on target, keeps us focused on what we said we were going to do and stay on target with respect to our objectives. So that's really what I have to share with you today. And of course, Nadia and I would like to acknowledge our team here at the NicotineDependence Service and also our funder for the program, which is the Government of Ontario, more specifically, as Leah mentioned, the Ministry of Health and Long-Term Care, the Health Promotions Division. And with that, we will open up for questions that you might have for either myself or Nadia, and we would be happy to address them as best as we can.
Okay, so we'll use the, if you use the mouse, you'll be able to scroll and see some of the questions. So I'll let you know, let's just keep going down. I'll let you know when I see the first one. Okay. Here, those answers. Yeah.
Okay, so there's a question here related to the lower percentage of addiction agency participation. The question is that due to a belief that quitting everything at once is too much, or a belief that smoking is the least dangerous harmful of addictions? That may be the case in some scenario. Of course, the responses that we did not, or the agencies who we did not hear back from, that could have been the reason for that. But the ones that we did hear back from, but were not able to get them operational, that had to do often with the fact that when deploying smoking cessation medication, we do need a medical structure in place in order to be able to dispense the medication through those agencies. And many of these agencies, they did not have a medical structure in place. And so that became a barrier in some sense at the beginning. And this is something that we have worked out over the last little while. And so we're hoping to get increased rate of adoption as a result of that. But to go back to your question, whether the belief that quitting everything is difficult or the belief that smoking is the least dangerous of them all could be playing a factor in many of the addictions agencies who did not respond with an interest to integrate the STOP program within their organizations. Okay, so fitness of the lungs is just as important as sleeping cessation habit. Is it possible to do this?
Okay, here, let's answer this one.
So the question here is, are our physicians trained to use MI, and how did we get their buy-in for the training? This sounds like a question that could be to the field as well. So I'll answer it for our scenario here. Our physicians are trained in MI and using MI in dealing with their patient population. And we are a bit of a, I guess, unique case scenario in the nicotine dependence clinic because we have a fairly strong focus on integration of research, integration of education within our practice. And this is part of our effort to cut down the cycle of 10 to 18 years between discovery and implementation or integration into practice. So the buy-in, it wasn't necessarily easy. However, having input and adoption of the idea from the level of the medical directors within the organization, as well as the head physician within the clinic, does definitely help along those lines. I mean, generally deploying trainings to physicians is a difficult task, often because of the great demand on their time. But having a comprehensive strategy where you're involving input from physician in terms of what sort of training would work and how the MI training could be delivered to them would be definitely beneficial in getting their buy-in, because I think the validity of MI within clinical practice is obvious, and most physicians would probably agree with that, and they're probably already implementing some components of MI within their practice anyway. Are there other questions that you may have? Are we able to take questions through the teleconference line? Okay. So if you have any questions, please do type so that we can see and address them. Yeah. We'll go to so the question is, what about the smokers who are not going to family health teams, community health centers? How are they accessing smoking cessation intervention? So there is a bit of a gap within this province in terms of reaching all smokers. In the past, we have implemented web-based enrollment or our mass distribution model, where people would call a 1-800 number and enroll via the phone and receive medication by mail to their preferred address. We are no longer doing those. However, this is something that we are proposing to the Ministry of Health in terms of additional support or continuous support in that area, so that we can reach smokers who are not necessarily reached by the family health teams or the community health centers. Now, I did say that we are partnering with 34 of the 36 public health units, and one of the things that we do what the public health units are actually quite proficient in doing is reaching out into the general community and recruiting people from those communities in order to deliver care to them. And so our model of care with the public health units is the Stop on the Road program. You may be familiar with that, where we partner with PHUs to hold workshops in various communities across Ontario. And to date, after a few years of implementing Stop on the Road, we have been to well over 150 different communities across the province. And if you think about how many cities and towns there are within the province, we have pretty much been to most of them with 150. And so we are able to hold a half-day-long workshops within those communities in collaboration with the public health units. And to participate in those workshops, people do not necessarily have to be involved with any particular family health centers or community health centers or any other organization that could simply respond to the call for the workshops and participate if they meet the eligibility, which is, again, that they should be smoking and intending to quit smoking in the next little while. So there are some delivery systems in place to capture those individuals. However, it is not an ideal state, and we are definitely always striving and making the case for creating systems that will reach out to those who are not necessarily reached by healthcare organizations. Do we make follow-up calls to this? So here's another question. So do we make follow-up calls to patients to determine if they are following treatment plan? Who makes the calls? How do you share feedback among team members? So we do follow-up calls. We call in our family health and community health center, CHC, as well as addiction agency implementation models. We do calls at 3 months. We then again repeat the calls at 6 months and 12 months. The intention of those calls are there's a dual intention. One, we want to know how the treatment is working out. So that's an evaluation follow-up call. But at the same time, when we identify the need for individuals to re-engage with treatment, we definitely advise them to re-engage. And those agencies where they are receiving the treatment, they are definitely going back if they are remaining within the treatment, and there is a drop-off to treatment, as you can expect, or loss to treatment. But there are calls being made, and patients are going back to those agencies to continue their treatment, and so there is touch points even after initiation of treatment. And the call, who makes the calls? Well, our staff here, who are research staff, will make the calls. And the feedback among the team members are shared via our biweekly webinars, our teleconference that we have, but also through quarterly feedback reports that we generate for each of the agencies that are participating with the STOP program, and we deploy them 4 times a year at least. Okay, thanks very much, everyone.
Thank you.
So thank you again to our presenters, Sarwar and Nadia. At this time, we're going to wrap up a few minutes earlier as there seem to be no further questions. A reminder that a link to the post-learning assessment and course evaluations will be sent by email, and you have 1 week to complete the learning assessment in order to receive your letter of completion. If you did participate as a group and during today's webinar, please make sure to email Perazad Hathadaru at the email address found on the page. As a reminder for those of you who are also interested in attending the next implementation series of implementation webinar of this series, the following webinar will take place on March 3rd of 2015, where we will specifically be looking at implementing tobacco cessation programs in addiction agencies, and we will have 2 guest speakers presenting on that topic as well. Thank you very much, and we hope you enjoyed this.